Well, hello, friends. This is another wonderful day of Kidney Talks with the Ron and Joy Paul Kidney Center. I'm your host, Reverend Dr. Kendrick Curry, Pennsylvania Avenue Baptist Church, and our partners are always the wonderful, the dynamic, and great MOTEP, which is the Minority Organ Tissue and Transplant Education Program with Dr. Clive Callender, and certainly the George Washington University Ron and Joy Paul Kidney Center. Today, we have some wonderful guests that are going to help you understand the road to liver transplantation. We are graced today by having Dr. Stephen Gray, who is a surgical director in liver transplantation at the George Washington University Transplant Institute. We also have Dr. Lent Johnson, who is executive director of Liver and Pancreas Institute at the George Washington University Transplant Institute. Both are hepatologists and professors there. And so you have the best that are going to be here to answer your question. So get them ready to put in the chat. And now I believe we have a presentation that talks about the road to liver transplantation.
All right, I'm just going to share.
That's great, Dr. Johnson.
Great. I'm just going to share my screen. One second. Sorry, one second. It's not letting me share. It's not letting me share my screen. 1 second here. It's Dr. Johnson. Do you want to talk for a second while I try and upload this? I try and upload the slides.
Okay. So you're on the present button.
Yeah, but it won't. It's something with the settings on the computer aren't letting it do. It says something with my Chrome. Sorry.
I see. No, well, I can certainly begin and with this chat today. First of all, I want to say hello to my adopted godfather, Dr. Clive Callender, who is clearly the pioneer for those of us of color who have pursued a career in transplantation, and it's always great to be in his presence. Dr. Curry, also pleased to be back with you. I think that we had an event probably pre-COVID that
Yes.
I was able to participate in. So thanks for having us back to talk a little bit about liver health and liver disease and transplantation. I think that the first thing to start out is to really talk about what the liver is and what it does. And the liver, first of all, is the largest organ in our body. It generally weighs anywhere from 2 to 3 to 4 pounds, and is, if you will, sort of the manufacturing plant as well as part of the waste management plant for our body. It has a lot of very important functions in regards to making proteins. Some of those proteins are involved in helping us to clot if we start bleeding. Other of those proteins are maintenance in terms of maintaining our health and wellness. It also has and plays a big role in metabolism. So all of the nutrition that we eat that gets absorbed in our intestines, actually the blood flow from that and is carried into the liver for the liver to metabolize that into energy. And then lastly is a part of our waste management system. So it helps us detoxify various chemicals in our body. as well as to eliminate waste that is created as our body metabolizes our nutrition and other entities such as red blood cells in our bloodstream. So it plays a very important function. Um, it typically is thought of, at least by the surgeons, as having two separate lobes, a right and a left lobe, but both lobes have the same function, and therefore there's not a differential between one side or the other. Um, there are a number of conditions and situations that can cause an unhealthy liver. Certainly, the things that most people think about are things such as viruses, and particularly the viruses that particularly attack the liver, including viruses like hepatitis B and hepatitis C. Um, we also think about alcohol, and certainly alcohol is something that is metabolized again by the liver, but an excess of alcohol can overwhelm the metabolism system and cause scarring in the liver. And any cause of scarring in the liver, whether it be alcohol, whether it be viruses, whether it be some genetic diseases, um, also bile duct diseases, can cause scarring, and scarring in medical terms is called cirrhosis. So all cirrhosis means is scarring. It doesn't really tell you from what reason that the liver has scarring in it. And it is at that point that patients end up seeing us and seeing our medical colleagues that are involved in helping to um, manage patients with liver disease and liver injury. The last thing I would say is that nowadays the most common uh, liver disease in the United States is what we call uh, fatty liver disease, or NASH, which stands for non-alcoholic steatohepatitis. And essentially, fat in the liver can actually cause the liver to be inflamed. And that chronic inflammation of the liver is what can lead to cirrhosis or scarring as well. And so, I think that particularly individuals who have a very high BMI or body mass index, who are significantly overweight can fall into this category. And also patients who are diabetic can fall into this category. So having an assessment of your liver, particularly if your annual liver blood tests are elevated, is something that should be essential to pursue, because those things can be reversed if caught early enough. I don't know, Dr. Gray, were you settled at this point, or there you go? Okay.
All right. Before Dr. Gray begins, let's just follow up with the quick question. I do, and I want maybe he'll answer this in the presentation. But can the scarring be prevented, or can it be reversed? I think that's something that we love to hear for our audience. Dr. Gray, feel free, or Dr. Johnson, feel free to answer. Either way is okay with me.
Well, since I'm the wingman, I'll let Dr. Gray take the lead on that.
Okay.
Hey, Stephen,
You're on mute, Dr. Gray.
Best thing I've said all day. Anyway, the liver has an amazing ability to regenerate itself and to heal. But by the time you get to the cirrhosis stage, the healing, that you can't really heal or regenerate from cirrhosis, from that scar tissue. But before you get to that stage, in during regular checkups with your doctor and regular routine health maintenance, oftentimes liver problems are caught and they're usually reversible at that stage. But by the time you get to end-stage liver disease, where you have cirrhosis and the complications of liver disease, they're no longer reversible. So I appreciate the opportunity to speak to this group again, Dr. Curry and Dr. Callender. It's a privilege. So we're going to just kind of go over some things, a couple of things, just to rehash the topic from before, and then a couple of new exciting things that have happened here at GW since the last time we spoke, and then we'll leave it open for some questions. Liver transplantation. So liver transplantation is the standard of care for end-stage liver disease. Organs, as we talked about before, are a constrained resource. There's not enough organs currently to go around for everybody. And we've seen, that in this area of healthcare, there are definitely disparities, as there are in all areas of healthcare. Disparities in access to the evaluation, access to just care, being listed, and then also differences in outcome, that some of which are kind of predetermined because of how late people are referred into the process. So yearly there are around 12,000 candidates added to the list. There were 8,000 liver transplants, a little bit over 8,000 liver transplants that occurred in 2018. This graph just shows that from the most recent data from 2015, that the majority of patients are still, a lot of patients are still waiting on the list. Some patients are removed from the list from a variety of reasons. Sometimes it's because they get too sick. The other reasons people are removed from the list is because they've underwent transplant. So transplant is a pathway, where you start with, and there's lots of moving parts within transplant. The biggest part of it is, there's the patients. First off, you have to have a patient with liver disease, and that patient needs to figure out access or be referred to a doctor for quality hepatology care, which is what our medical colleagues they would provide here. On the other side of this slide, there's what's called the OPO, or the organ, and so that organ donation piece, you really can't separate organ donation from transplant. And as a transplant surgeon, Dr. Johnson and I think we're very much involved in the donation process. And one of the things here is hopefully we can also start to dispel some of the rumors associated with donation. As you can see on the slide, it's a multi-step process to get from person with liver disease and a donor all the way down to the spot at which you have a liver transplant recipient. Organs for transplant are the next slide. Are distributed based upon what we call a model for end-stage liver disease score. So this score utilizes all laboratory values. The creatinine, which is a measure of your kidney function, the bilirubin, which is a measure of your liver function, the INR, which is a measure of your liver function. Those things all go into this score, which the score can range anywhere from 6 to 40. Prior to this scoring system, there's more objectivity into the scoring system. It was like, was the patient confused? Does the patient have a big belly that's full of ascites? And then it took some laboratory values into that. Now with this score, it's much more objective, which has led to some more equitable distribution or listing of patients once they're on the list for transplant. We can go on to the next slide. So this slide here, though, what it shows is how where people's score varies by the part of the country that they're in. This slide is actually, I think, is a success story, though, because in 2022, this slide, you don't see a whole lot of differences in color. It's all kind of in that purple, the medium to dark purple, as opposed to around 5 years ago where you had extreme purple on, like in the New York area and the California area, then a lot of very light purple throughout the rest of the United States, where people were getting transplanted very low scores in some areas and people were dying with similar scores in other areas of the country. So again, I mean, I think that what we have seen is how the playing field has been leveled out over time. So again, this whole process is a stepwise process to transplant. And each one of these steps, whether it's the patient with the disease, access to hepatology care, referral to the transplant evaluation, being put on the list, the actually making it to the organ transplant itself, there are areas in which you can interject issues and areas which we can work to improve them. One of the big areas which I think at GW, which we were very interested in improving, was access to quality hepatology care and access to a transplant program, that was easily reached, both physically, but also that was centered or was focused on patient-centered outcomes. So, where everything we're doing is trying to be centered around making it easy for patients. Again, one of the keys to this is organ donation. And this slide here has up the name of a bunch of organ procurement agencies, some of which have changed names. Alabama Organ Center is now Legacy of Hope. WRTC, which serves the DC area, is actually about to be known as Infinite Legacy. That's going to be that's actually going to be their new name, again, because it's an opportunity for for somebody who, even in death, to contribute to saving somebody else's life. A potential organ donor can contribute around 7 organs, not including soft tissue and the other things, to the organ bank, and that can save 7 lives. So there's the opportunity that, although a tragedy has happened to you or your family member, you can bring about a huge change, a life-saving change to somebody else. And one of the key things with this, and the reason I have the driver's license on there, is that self-designation of being a donor. If you self-designate as a donor, it doesn't change anything that happens to you in the hospital. I mean, it's never changed what happens to you in the hospital. But what it does do is it allows your family, who is going through probably the worst day of their life because you've had an accident or something bad has happened, to know what your wishes are. That way they can honor your wishes by allowing you to potentially give life to somebody else. So the breaking news, of which changed since the last time that I spoke with you, is how our transplant center has actually performed its first liver transplant. We've actually done 11 liver transplants since this time. So our first liver transplant was actually a liver kidney transplant that happened in April of 2022. And so again, we're very excited about the fact how we've actually completed our first liver transplant. So that coincides with the kidney transplant program that's already here, and the pancreas transplant program that's coming within the next few months. Next slide. So a couple things I think which are uniquely interesting to this audience. This is a paper that I wrote a couple of years ago when I was at UAB, and what we were looking at is what we've seen is we see a lot of older adults who are undergoing evaluation for liver transplant. And what we've noticed is over time there was a 2.5-fold increase in liver transplantation in recipients over age 65. And I know 65 isn't old, but for liver transplant, that's an advanced, that can be considered to be an advanced age. There's been no consensus though for the upper age limit for transplantation. It's kind of left up to what each transplant center feels. And when we leave things up to what people feel, oftentimes that allows for the interjection of a disparity or our prejudices and our views to come into play. We saw that in the variation in liver transplant rates amongst the elderly. We do see, though, that among ethnic and racial minorities, such as African Americans, that the chronic viral hepatitis, alcoholic liver disease, and fatty liver disease are more common in these minorities. But despite these high prevalence of liver diseases in African Americans, African American candidates only account for a fraction of patients on any given transplant waiting list. For example, at the University of Alabama in Birmingham, where I used to practice, only 14% of the liver transplant referrals, so patients who were being sent from their doctor for potential liver transplants, were African American. Now that's interesting though, because the state of Alabama is 25% African American. So either that means how we're getting better health care and we're not getting as sick, or people aren't being referred to liver transplant services. And I think we know which one that is. And so, and that, as we showed in the previous slide, that lack of referral could be clinician, it could be systemic. It could also be, though, that we automatically disqualify ourselves for transplant by saying, well, no one would want to transplant me because I have X disease, or I have X condition, and that makes me not a desirable candidate for transplant. So next slide. So what we found in our analysis is we saw, again, that a disproportionately lower percentage of liver transplant waitlist candidates were African American, despite this higher end-stage liver disease burden. We saw that a higher proportion of African American candidates were hospitalized at the time of listing, and because they were hospitalized, they often had a higher liver sickness score. So what that means is how these African-American transplant recipients, and this is a nationwide data, they're not being referred when they're just having liver disease or early on in the process. They're only being seen for transplant once they get really sick and they're requiring hospitalization. We did find how older liver transplant candidates had a lower incidence of transplant than younger adults. We found that older African Americans were less likely to receive liver transplants than older Caucasians. And we compare, but what we didn't see amongst the younger patients, we did not see a difference in transplantation rates among young patients. So that was yet less than 65. But compared with younger whites, both older whites and older African Americans were more likely to be delisted, which means how they're more likely to be taken off the list, likely because they got too sick for transplant or no longer a desirable candidate for transplant. But then we saw no difference in really the wait list outcomes for younger African Americans compared with younger whites. Next slide. So, again, we've seen how in other literature how subjective parameters limit the referral for transplantation. So there's an observational study from 2003 to 2008 in France, looking at factors for which patients were being referred for transplant. So these were patients actually with alcoholic liver disease. Primarily with alcoholic liver disease. Of those, 21% of this 381 people were deemed to be candidates for transplantation. But we see here how one of the things that really drove it was physician empathy, meaning how my doctor felt sorry for me, or could empathize with, or could see the disease from the patient's perspective, and was trying to help, wanted to really help that patient. They were advocating for that patient for transplant. That was one of the largest drivers of whether or not people got referred for transplantation. Next slide. And again, even within, people would always say, well, what about the difference in insurance? Well, this study from the VA showed that, even within the VA, which is a single payer system, meaning everybody had the same insurance product, that liver transplant was only mentioned in 21% of patients who would otherwise be deemed by national criteria as being acceptable for liver transplantation. Things that made people unlikely to be accepted for liver transplantation were older age, or being referred for transplantation were older age, prior alcoholic liver disease, or being African American. But again, active alcohol use was in this setting was the most commonly documented or inferred contraindication for liver transplant referral. Again, we can go on to the next slide. But what we have seen over time is how we have increased the amount of people overall undergoing transplant, and we're able to, and we've shown this by increased survival amongst patients listed for transplant and increased transplant rates. You can go on to the next slide. So with that, I'd like to show you this picture of part of our transplant team here at GW. You've seen Dr. Johnson on the slide, Dr. Melanson, who I don't think is a stranger to this group at all. And then Dr. Vahor, he's our hepatologist. And then we're missing two people from this slide. Dr. Serrano, he is another one of the surgeons. And then Dr. Abu Talib, he's another one of the hepatologists. But the other important part with this slide to note is you can see the escalator in the background. And that for us is important. And that's what always reminds us of the access to transplant, because that's the escalator that takes you down to the metro. So pretty much any place in DC, utilizing public transportation, you can get to GW utilizing public transportation, which I think is a huge advantage for patients who oftentimes struggle with with mobility and struggle with the ability to get to a tertiary care center. So we don't take the fact how we're on the metro route to be to very lightly. We want to make sure that we are using that to every advantage that we have. Next slide. And with that, I'd like to say thank you for the opportunity to talk, and we're more than happy to answer any questions that you have.
Well, definitely. Thank you so very much, Dr. Gray and Dr. Johnson, and for the presentation and early part of the discussion. I do want to jump right in and encourage all of those that have questions that are viewing by Facebook or YouTube or social media. Let me just say, put your questions in the chat. This is an important information, and the doctors are here to be able to answer your questions. One of the things that was being asked in Facebook by Miss Joyce Austin. She's asked it a couple of different ways. She had many questions, but she was told by a doctor that she has fatty liver disease. How can she reverse it, or can it be reversed? How do you take care of it?
I mean, I think with fatty, if it's still at the early stages of fatty liver disease, doing those normal health maintenance things can really make a difference. You know, losing weight, if you're diabetic, controlling your diabetes. You know, getting active. Those things can definitely help. Can help to slow down the fatty liver disease and sometimes even reverse the fatty liver disease.
Is fatty liver disease the same as hepatitis?
Not really. I mean, fatty liver disease is really one of the manifestations of, you know, some of those American issues, right? Hypertension, obesity, diabetes, high cholesterol, those things. It's the liver's kind of manifestations of that. The other way which you oftentimes can see fatty liver disease is from alcohol. But again, in the non-alcoholic, it's usually related to It's usually related to their hyperlipidemia, their high cholesterol, their other medical issues. But you know, one of the things is, like, you know, you can just like you can lose weight other places in your body, you can through exercise and diet. You can decrease the amount of fatty liver disease as long as we haven't already made it into the cirrhotic stages.
With regard to the, I think they call it the ALT, that is often given with regard to your blood test. Can you describe what that is, and also help us begin to understand how to think about the right ranges for that number in terms of the progression or the road to liver transplantation?
Reverend Curry, let me comment on that, and as well as the
Okay.
prior question, because there are some nuances around that question in regards to whether fatty liver disease is hepatitis. And the reason I mentioned that is that fatty liver disease can cause inflammation in the liver, and that inflammation is the itis part of things.
Right.
So when we think about hepatitis, we primarily think about viruses that cause inflammation, but the fat in the liver doesn't necessarily have to cause, but it can cause inflammation just in the same way that viruses can. And so that's the part of steatohepatitis. And it ties into your current question, because oftentimes the way that we discover that is that the liver enzymes, which are ALT and AST, are reflective of injury to the liver cells. And so the normal levels are usually somewhere around 35 or so or less. And if there's injury to any of those liver cells, then that number goes up, because those enzymes are released from the liver cells into the bloodstream. And so oftentimes that's the first signal that there may be something going on. And generally that's picked up in the routine blood work that you get on an annual basis if you have what we call a comprehensive metabolic panel.
Mhm.
And then from there, oftentimes patients are referred either to get an ultrasound of the liver to look for abnormalities and or a CT scan.
Okay.
Um, so so those are kind of the nuances around what fatty liver disease can do, and also the importance of having those liver function tests as a part of your annual physical blood work.
Yeah, that's super helpful, because I do believe that a lot of folk on here really want to know. Can you tell me a little bit about some of the symptoms to watch out for as it relates to cirrhosis? I know we talked about that earlier as a scarring, but are there some symptoms that we can begin to talk about with regard to cirrhosis?
Dr. Gray, you want to
Either
take that
Dr.
one?
Gray, Dr. Johnson.
You're on mute.
You're on mute,
So,
Dr. Gray.
yeah, so sometimes it I mean, it can sometimes sneak up on people. I think people when they become symptomatic, some things people notice is sometimes like yellowing around the eyes, but that's usually a little bit on the later side. Sometimes it's patients. I mean, I know I've seen a fair number of patients who are referred to us from their doctor because their platelet count is low on like routine lab work. Um, sometimes it can be like tiredness, or slight confusion, when they start having encephalopathy. But a lot of those signs are late. A lot of times it can be kind of subtle early on. I mean, Dr. Johnson, if you have other things you could think of.
Yeah.
No, no. I mean, I think that gives a pretty good summary. For advanced liver disease, and even sometimes for some of the acute liver diseases, patients can present with jaundice or yellowing
Yeah.
of the
Of the
eyes,
eyes. Yes.
particular. And that's generally you either notice it yourself or someone notices it for you. And that can be an indication. Um, Other things are generally more advanced down the road in terms of swelling and things of that nature. But I would say most times, it is picked up either by just the lab test or by the appearance of jaundice.
Okay. Well, thank you for that. There are many, many questions, but I wanted to bring in Dr. Callender. Dr. Milan's son is away for right now and not available to be with us. But Dr. Callender, what are the questions that emerge from the presentation and or that you have with regard to um, liver transplantation or liver disease?
Well, there are many, but I guess one of the things that I recognized back in the 90s was the presence of the so-called green screen. And in many ways, Stephen Gray mentioned it, but didn't call it that. And I thought that a lot of the discrepancy uh, between why there's so many African American liver patients and so few actually get to the transplant list is related to their inability to have insurance or the ability to pay. And I call that the green screen. Do you think that still exists today?
I mean,
Dr. Gray?
I think that you. I mean, I think it exists to a certain extent. I mean, I would hope that we've gotten better, but I think when you look at just when you look at the communities in which oftentimes we live in, you don't have the same access to care that you do living in a higher socioeconomic areas of a city. So I mean, I think there's systemic things. There's kind of those systemic things that happen, or the difference in quality or your ability to be able to even go see your doctor, that can definitely affect it. I think that I think that there probably still are some transplant centers or physicians who treat their publicly insured patients differently, or see their publicly insured patients in a different location even than their privately insured patients. And so, I mean, I think it still exists. And I think we've become more in some ways more nuanced, maybe in the way which we talk about it, from the standpoint of, we look at it more like on a neighborhood, maybe on a neighborhood basis, as opposed to an individual. But I think you definitely see systemic issues with access. I know there was an article that just came out in one of our transplant journals, just looking at where you live in the country, where the economic depravity in your area of the state or the country can affect your access to transplant care. So I mean, I think it exists, but maybe we're looking at it on not on on an individual basis as much anymore, as we're looking at it on a larger basis. And I mean, I think it definitely exists at the lower basis. I think one of the keys, though, is how, is for being, being a minority, is to make sure that you are as informed about your healthcare situation as you possibly can be. When you go see the doctor, if you have someone in your family who is in the field, ask them, the questions, and help them and develop your questions before you go. And then the other thing is, if your doctor, if you ask your doctor a question and they can't answer it satisfactorily, or they dance around the question, then you need to make sure you kind of hold their feet to the fire till you get the answer that's right. Because I mean, I can just tell you, even from my family's my personal experience, I've had family members, and I'm like, they told you what? Well, this is my sister. I'm like, did you tell them that what I do, or what dad does, or what your sister-in-law does? No, I didn't think it was necessary. Well, unfortunately, it does, and unfortunately, that can impact your care. So, I mean, I think that, the informed patient, the patient who is an active participant in their care, whether it's liver disease or heart disease or broke bone, whatever it is, routine health maintenance, that patient is going to have a better healthcare experience than the patient who just says, well, whatever you think, doc. That's the difference.
I had another question that
Please.
had to do with you mentioned the MELD score, and I had recently had a patient, and they didn't know anything about their MELD score. Do the doctors share the MELD score with the patients, or is that just the lab determination that the patients are unaware of?
I mean, I think I can tell you, in our practice, we share the MELD score with the patients. I mean, I think that the hepatologists who work with us, they definitely share the MELD score with their patients. But I mean, I think too, liver disease is an area which I think people are getting more and more interested. Maybe physicians are getting more and more interested in. But I think that there's even a lack of knowledge, or maybe not knowledge, but comfort with taking care of liver patients amongst a lot of physicians. So I think that, people may or may not, it's not that anybody's hiding the MELD score from them. It's not even something that people are even thinking of, right? I mean, I think Dr. Johnson and myself, we spend a lot of time with people with liver disease. So the MELD score is just kind of like one of those words. I mean, I'd be rich if I got $1 for every time, or even 10 cents for every time in a day I say MELD. But I mean, a lot of doctors, they probably aren't even, you may not say it all week, right?
What does it mean, MELD?
So model for end-stage liver disease.
Right.
And like and it is a score that is currently calculated utilizing laboratory values. It's currently calculated based upon your renal function, your bilirubin, and then your clotting function, your INR.
Okay.
So one thing I would say is that the Dr. Curry had mentioned about empowering people, but one of the things that individuals can do, if they have their lab tests, you can go on the internet, and there's a MELD calculator that you can just plug it in yourself, and it will calculate a score for you. Now, the interpretation of that, probably requires you to consult with your physician and so forth, but the actual number you can get if you have access to your lab work.
Well, I mean, I think, and to go along with that, I mean, I think, as Dr. Johnson said, nowadays, patients have access to, most patients have access to their labs, through a portal. And then you also have access to Dr. Google. And you got to be careful with Dr. Google, because Dr. Google will get you in trouble sometimes. But
it'll get a lot of times, yes, sir.
But I mean, I think that it's helpful. Because I think, like, most of them, I think, especially if you can stay towards some of the institutions which provide patient care information, like was it Medscape that provide free patient care information. Mayo Clinic does an incredible job of providing free patient education, like for Meld Score and whatnot. And those are, and it even provides you with with the information. I agree. Dr. Google cannot be your only source of information.
Absolutely.
But I think that sometimes when your doctor's giving, when you're not comfortable with the answers, and you just want to double check, I think that that's a reasonable place. That can be a reasonable place to start. And then the other part is how, again, you being your own advocate. If something doesn't sound right, even if it doesn't sound right, it may not be right. And if it does, and if your physician is using a lot of big words, just get them to slow down. I mean,
Yeah.
like, it's like when I go talk to my accountant, like they start talking about stuff, I'm like, I don't have a clue what you're talking about, and it takes some humility on my part to admit that you don't understand. But again, you are the consumer. You wouldn't go buy a car without letting them explain it to you. So don't go to your doctor and leave without them explaining to you in a way that you can understand.
Yeah, one of the things I want to make sure that our audience is clear about is we want to provide you with as much information as possible, and we want to arm you with this information so that you are empowered. And I wanted to be clear, doctors, because there was a question that was asked. Every year we should have a physical, and with this physical, we should have some blood work that's done, and that is the first indication that you get of a liver screening.
I think that can be, but I think that when you go to the doctor, if you think about it, most of the time the doctor sits there and asks you questions, right,
Questions.
to get you
Yes.
to start talking, and that's one of the goals, right? Because if like one of my professors years ago, I remember saying how it's like every patient is like an exam, but they're an open book exam, because if you
Open
still
book.
keep asking them, they have the questions. It's just a matter of us asking the right questions and the patients answering, giving you that information. They have the information. So, I mean, I think it's the same thing there. I mean, some of that conversation is just to find out, well, what's going on. Like, if you come and see me, you're like, well, my belly's getting big. We're going to look, we're going to try and figure out, is it too much cooking, or is there fluid or something that's being sequestered there that could potentially tip you off to another diagnosis.
All right, Dr. Callender, what do you think?
Yeah, well, I actually had another question.
Please feel free.
It has to do with what Dr. Johnson does a lot and what Dr. Gray does as well. And that is, what is the role for transplantation with liver cancer?
So, I mean, primary liver cancer being hepatocellular carcinoma, or liver-based cancer, or even some of the bile duct cancers. I mean, that's a major indication for liver transplantation in the United States. So it's one of those things where, if you find out that you have it, they should send you to a hepatologist or a GI oncologist, or a transplant center, and we take a look and we see if you meet criteria for it. And oftentimes, you will, and that is definitely a major indication for liver transplantation.
Yeah, the odd situation is that most patients, when they hear they have liver cancer, most of those patients will have cancer that has spread from another site, and so that we consider metastatic cancer. And so even if the cancer is in the liver, if it is originated from another site, we don't consider that liver cancer. We just consider it the primary cancer from whence those cells came. So for instance, if somebody has colon cancer and they've found that they have some spots in the liver that are cancerous, that are related to the colon, that cancer in the liver is still colon cancer, as opposed to what Dr. Gray was
I
mentioning,
get it.
which is cancer that has originated in the liver from the scarring process. And that's where transplantation comes into play.
Okay. Audience, feel free to put your questions continually in the chat. Doctors, they are very appreciative for the information that you're sharing, and particularly a road to liver transplantation, but we really want to keep them healthy to begin with. And I'm grateful for you answering the basic questions before we have to come and see you all, because our goal is not to have to come see you all.
That is correct.
I had another question that
Dr. Collins.
has to do with something that you mentioned in your talk, Dr. Gray, but is a source of a lot of discussion. How long must you be off of alcohol before you can be safely transplanted? If your liver disease is caused by alcohol.
Yeah. So, I mean, that's a great question, Dr. Callender. I mean, things have really changed a lot. There used to be, most places would say 6 months. But again, it's one of those areas with a lot of variability, right? You had centers that would say you had to be sober for 6 months, but they couldn't, you really can't go back and test to figure that out. But they'd ask you how long you've been sober. You had other centers that said you had to be sober for 6 months plus, or you had to be sober for 6 months plus you've had to have been involved in some type of a rehab activity. In some places you could be sober for a year and they'd still say you had to be involved in some rehab activity. Nowadays, there's been a lot of literature saying how the patients with acutely decompensated, meaning very sick alcoholic liver disease, with good social support, with and without with good social support and good insight into the disease, how you can safely transplant those patients then when they are in the hospital with their acute liver disease, and that is life saving. So I think that the pendulum has swung, but the issue again becomes, though, in that setting is what the person who you're talking to, do they understand you? Are they giving you are they looking at the whole person and not just the fact how they've been drinking, right? Because I think we all know there's a difference between the person who, like during COVID, you started drinking a glass of wine a night, and then you ended up drinking 2 glasses of wine a night, and then you ended up on a bottle of wine a night, and it kind of snuck up on you, and you really had never had, but you'd always held down a job, never had a DUI, still involved with your family, still doing all those things, but now you have this drinking problem, and you have this, and your liver is failing, and you're in the hospital. That's a different person than the person who is socially isolated, ran their family away, still addicted to alcohol, and doesn't have and has no kind of social support. Those are two different people. Right. And so I think that at least our approach to it is very individualized. We get our social worker involved. We do a complete psychosocial evaluation. And then, if it's a choice, if we think that the best opportunity for your survival is transplant now, we'll go ahead and do that. And I think that a lot of places in the country are doing that. And then we plug you into rehab afterwards. Because the rate of people going back to drinking with that strategy versus the rate of people going back to drinking, problematic drinking, even with waiting 6 months, is about the same. And when you wait the 6 months, you had a lot of people who were dying. So I think that is a huge change, a swing in the pendulum. I think that it's still problematic because we need better criteria to make sure that my own personal biases aren't falling into it. I mean, the joke was always that when we were in Birmingham, this wasn't necessarily for alcoholic patients, but for any patient who was a teacher, how like they knew I had a soft spot for teachers because my wife was a teacher. And so, you definitely would kind of advocate for those people. And so, especially for us, where there are not a lot of us not a lot of transplant centers who have people who look like us and may understand us, or may understand even some of the unique social challenges that exist, that's problematic when things are not very well drawn out. So I think that, again, it's one of those things where you have to, you need to feel comfortable with, as you're going through it, you need to feel comfortable with your team. But I mean, as long and the short answer is to Dr. Callender, is I think that people are starting to look at, the alcoholism is more of a disease. And so they're looking at not, it's more than just a behavior, it's a disease. And you're looking at it more so from the standpoint of, we need to fix the life-threatening part of the disease first, which is the liver failure, and then get people plugged into rehab afterwards and give them a shot to kind of reclaim their life.
So how successful after one has a liver transplant? What's the life expectancy?
Um, we quote people a 1 year survival around 94%. 3 year survival starts to get out to around in the low 80, in the high 70s, low to mid 80s. That's kind of taking all comers. Different patients are going to have different life expectancies depending upon what their comorbid, what their other diseases are that they have when they come into it. But I mean, you can get pretty close back to a normal life expectancy afterwards if you're you know if you make it out of that first the make it out of that first air the kind of the first year or so after liver transplant.
Mhm.
But a lot of it's driven by the other comorbid conditions, the other medical problems that people with liver disease that they have when they present to us, when they show up in our office.
Yeah, and Reverend Curry, I still have patients, and I know Dr. Calendar also still has patients from 25 years ago or so that still send me Christmas cards every year, and are still going very, very strong. Uh,
Well, thank you for thank you for that, because I do want to have some hope on the program, so that
yeah.
folk will understand that you all do a great work. Your hands are gifted, and you're blessed to be able to do such a thing, like you do with liver transplantation. But people can live productive lives in the aftermath of transplants. So,
Absolutely. In fact, when I was at you, when I in my prior job, we had one of the nurse anesthetists who had a transplant, and she would go and tell people she'd find them either immediately after transplant or while they were waiting in the pre anesthesia area, and tell them like, "Hey, I had this. You can get your life back." I mean, I'm sure Dr. Johnson has
mm,
done it also.
mm,
I've interviewed fellows for transplant training who've had liver transplants. My former chair of surgery, he'd had a liver transplant. So
okay.
people go on. You can live people run marathons. People do all
Wow.
types of things after liver transplant and kidney transplant.
Sure.
We're not transplanting people. I always joked, I'm like, we're not transplanting you to put you in a bubble. We're transplanting you to get back to doing the things that you want to do, whether it's going back to church, whether it's going to the movies, whether it's traveling the country. We're to get your life back. Like for me, I think that like when we transplant a couple of 30-year-olds, I'm like, nothing's going
Wow.
to make me happier than when you tell me you found a job again. Because again, when you getting back in the workforce, in your mind lets you know that you're getting better. And
That's right.
so that's
That's right.
that is those are the things which we're really looking for in this.
Well, this has been a wonderful, wonderful program, and I'm so grateful for the time we spent together. And we have to have you all back just to share even more, because this is a critical subject that we must discuss, and we don't often talk about it. We don't talk about liver disease nor liver transplantation as much as we probably should. So I'm grateful to you, Dr. Johnson, and to you, Dr. Gray, and always Dr. Calendar. Any closing thoughts from any of you gentlemen?
Well, this is Liver Health Month, isn't it?
That's correct. It's Liver Health Month, and that's one of the reasons we're having the show today.
Yeah, no, I think in closing, what I would say is that, and something that you mentioned, Reverend Curry, which is that, as much as we're in the business of helping people when they have severe and end stage problems with their liver, we're also in the business of helping preventing uh, that condition. And so,
Yes.
I think having individuals attuned to maintaining their health, getting their regular physicals and checkups and blood work, all those things can be very, very helpful in regards to into their own health. And this includes things like colon cancer screening, prostate cancer screening, and very soon there will be blood tests that can screen you for early cancers and things of that nature. And so
Hmm.
we just need to stay abreast as all of the information becomes available, and make sure that we empower our communities to be on the forefront of that information.
Absolutely correct. Dr. Gray?
I mean, I agree 100% with what Dr. Johnson just said. I mean, I think, the other part of the other thing is, I would hope that some of the things we've said, even though they're not related to liver transplant, those are kind of the more important things, because hopefully you don't need us.
That's right.
I would love to not be needed, but I think that, when it comes to, just routinely going and seeing your doctor and getting your lab tests and staying on top of your health maintenance, I think that's probably the most important thing that you can do.
Well, thank you. You've heard it from the doctors yourself, friends. Let's thank Dr. Gray, Dr. Johnson, and always Dr. Callender and Dr. Melanson. We miss you, but we will see you again on the show soon. Thank you so very much. This is just a wonderful, wonderful show, and we are looking forward to the next installment of Kidney Talks with the Ron and Joy Paul Kidney Center. Kendrick Curry, Pastor Pennsylvania Avenue, Dr. Clive Callender of MOTEP Minority Organ Tissue Transplant Education Program, and of course, the George Washington University. Thank you. Take care, and bye-bye for now.